Hi everyone, Sue here, and I just want to have a short conversation with you about something called thinking biases. This week we're talking about critical thinking and what that means within the domain of nursing practice. And it's important to recognize that when we apply critical thinking principles, and you've learned about that a lot, but also when we are inhibited from applying some of those principles. And thinking biases are really important to be wary of and to recognize, because they really inhibit our creativity, our ability to come up with innovative solutions in patient situations, and our ability to really communicate those. So a couple of minutes talking about 6 different thinking biases. Number 1, and think about this yourself as we go through them, confirmation bias. In confirmation bias, it's pretty simple. We believe what we want to believe. And we do that, so in the absence of just following the facts, we make the facts fit what we believe or what we expect, as opposed to following the facts where they take us. So we favor the information that confirms our pre-existing beliefs. So for example, if I have a patient who is acutely short of breath, presents to the emergency department with wheezing, can speak only 1 to 2 word sentences, has a history of asthma, then I may be assuming that that patient is having an asthma attack. See how all of those indicators lead me to suspect it's asthma. But what if there's more information that I am not accumulating or not taking into account? What if the patient has a fever? Does a fever fit with an asthma attack? No, it doesn't. Unless the wheezing is a byproduct of viral illness affecting their upper respiratory viral illness that may be impacting them in such a way that it is either causing them to have a flare-up of their asthma, or the viral illness itself is leading to it. Now, in this case, maybe treatment might be similar, but in the face of COVID, we would certainly want to test for that and other things. That's not maybe the best example, but you see, instead of following the facts, we assume what might be there. And I'll give you another good example. Once I was looking after a patient, and her only story, she was just about 52, her only story was she had some pain in her right arm, and she remembered that she worked in a warehouse doing some lifting. It wasn't really heavy lifting, but heavy enough. She remembered hurting herself, she thought, the day before at work. She was seen by the physician, the doctor sent her over for an x-ray, the x-ray was okay. They put her arm in a sling just in case. Just on the way out. So do you see the facts? It seems like she has a story that she's hurt herself. She's 52, she's female, x-ray is okay, put her in a sling. Just before she left, on a hunch, just almost literally as she was picking up her purse and ready to go, the doctor said, let's just do a cardiogram on the way out. Her pain was atypical, but what do we know about women? Atypical pain, right? She was having an MI. She didn't have any nausea, she didn't have any sweating, she didn't have any left-sided pain, she didn't have an elephant sitting on her chest, all of those things that we typically see with men. She was able to give a good story that might lead us in one direction, but we didn't have all the data, right? And we know that women present atypically. We know that 52 is a reasonable age to be looking at their cardiac complications. So that idea that in the absence of looking for all of the data that we need, we tend to make the data we have fit our pre-existing biases, right? So what we think is going to be the situation. It's so critical in nursing that we don't follow that path, that we make sure that we actually let the data speak. Conformity bias. Oh, and this happens a lot as well. I think all of these happen a lot. And as we go through this, maybe think about your own practice. When large groups of the population, or even small groups, the people on your shift, your small group here working in the course, those opinions and how people tend to think about things influence how we think about things. Have you ever been in a class where you're not sure where you're supposed to post something or what's supposed to happen, and a whole bunch of people maybe not be sure, and suddenly there becomes this consensus, oh, that's where we post it, but the instructions don't say that's where we post it, but as other people are saying, no, that's where we post it, you start to think, okay, that's right, somebody knows, somebody must know, and I'll go along with that. That's groupthink. It happens in lots of different ways in a hospital situation or in a community situation when you're looking after patients. Groupthink may happen when the whole team starts to think a certain thing. They start to believe a certain thing about maybe a patient's condition, a patient's status, a patient's diagnosis, other kinds of things. Happens all the time. The problem with groupthink is that we tend to, when everybody is believing a certain thing, something is going on, this is the situation, even if we start to have a niggle that maybe it's something else, we should look at something else, we tend to suppress ourselves because we don't want to go against the group. If everybody else is thinking one thing, I must be ridiculous to be thinking something else. And it really is significant because how groups work most effectively together is when we all think independently and come together and share our ideas, not when we all go along with the flow. So a really important bias is conformity bias. Aha. Now I would challenge you to say that you haven't experienced this, authority bias. And what authority bias means is that we think the person who has the greatest authority in the situation must be right. So the senior member of the team, the most senior nurse must be right. The charge nurse must be right. The person who's the most powerful, often in healthcare, I'm not a doctor basher, but often in healthcare, it's the doctor, right? So the doctor must be right. And we often see that. So we think the person in authority must be right. So even though I'm seeing something differently or I'm worried about something differently, that person must be right. It is really catastrophic to follow this authority bias. Because the expectation of all of us with the College of Nurses is that we are independent thinkers and we are responsible for our own practice. We cannot sit in a courtroom and say, but I thought the charge nurse knew. The responsibility is within each one of us to think ourselves, to really determine what is going on. Where is the information? Where's the clinical data that leads me to a particular line of thinking? And so a good example here is at the end of every single cardiac arrest, every single code, a perfect code, whether a patient lives or does not live. The last question at every single code from the person who is leading the code should be, does anyone have any other ideas? Right? Not, okay, we're done, I'm calling it. The question should be, does anyone here have any other ideas? So critical that we do not see a hierarchy, that we all have a responsibility to use our own voices. Oh, action bias. This one is intriguing. I hadn't really thought of this until I was doing some more work around thinking biases. And this one is quite fascinating, and I imagine it just in my own life and in my own practice. So when we have a situation of what's like ambiguity, we're not sure what's going on, we're not sure if we should do something or not do something, right? So that's the critical point. I'm not sure if this patient is okay. Think about long-term care. Do any of you ever struggle with, I'm not sure if this patient needs to be transported to the hospital or not. A patient's not doing well who may be a DNR in the hospital. I'm not sure if I should call the family or not call the family. It's subtle enough. So it's not an obvious situation. It's subtle enough. It's 3 o'clock in the morning. I'm not sure if I have to call the doctor about this or not. Are you starting to get that point? So it's the situation, the data, the information that you're assessing is subtle enough that it's not obvious, right? So a dramatic change in condition, we know how to respond to that. But in action bias, the situation is subtle enough that it is ambiguous. I'm not sure, right? I'm not sure. So I have a choice. Do I take any action or do I not? And often, it's an interesting one. Often people feel this need to take action, even if it might be counterproductive. I'm not sure if this medication would help or not. We better give that. I'm not sure if somebody should see this patient or not. I better get that. Now, sometimes it's productive in healthcare because even when we're not sure, we want to make sure that the best care follows the patient. But when we're talking about independent nursing actions in particular, it's really important that we make sure we know why we're taking that action. Is it because we feel the tension of this ambiguous situation and we don't like to live in tension? We want to know, what is the action plan? And what if the action plan is, I'm just not sure and I need to observe a little bit longer? That's a tough one, isn't it? So that idea of action bias, and that just recognizing that when we're uncertain about whether we should act or not, that tension often causes us to act versus not. Interesting, right? What about a framing bias? And this is an interesting one as well, because I think it has to do a lot with communication. And think about a situation where somebody has a really great idea and they speak beautifully and forcefully and commandingly, and someone else has a really great idea and they speak more timidly. They're not able to get their words out as effectively. Who do you trust more? It's not necessarily true that the person who speaks more effectively or presents their idea more effectively has the better idea. In fact, they may have a very inferior idea, but we tend to develop a bias based on that presentation. You know, if you see a glossy pamphlet for a weight loss program, let's say, versus a little flyer that comes in, we tend to think that glossy presentation is backed up by more success, more information, things like that. So key to remember here is that we focus on the data. That's becoming a theme, isn't it here? We focus on the data as opposed to the splashy presentation of the data. Always asking yourself, what is the data saying, right? What is my patient data saying? So that framing bias, I don't just look and see, you know, how splashy the in-service is from a certain company about how fantastic their device is. I look at the actual data that tells me, does it lead to better outcomes than something else? This is another interesting one. We talked a little bit about ambiguity before, right? We don't like ambiguity. We don't like being in a situation where we don't really know what to do. In the past, in this presentation, when I talked about ambiguity, it was about taking action or not, right? In a case of ambiguity, should you take action or shouldn't you take action? We typically want to take action. We don't like standing or waiting in that moment of tension, waiting for the situation to reveal itself more to us. In this situation, we're also talking about that ambiguity, the tension of that ambiguity. I'm not sure about action, taking action, which action should I take? Another part of that, and it's so fascinating, is that we tend to go in the direction of what is knowable versus what is not knowable. And this can be really dangerous because it means we tend to follow familiar paths. So and it's kind of an interesting language, right? So we subconsciously go toward what is known, the known knowns, versus what is unknown to you. Does that make sense? So we tend to follow paths that are familiar. This is the kind of thing I've seen done in this kind of situation versus what is unfamiliar, even though the data may say in this kind of situation you want to follow a different path. But you haven't seen that, you haven't worked with it, you're not certain of it, and yet you know how to do something else, even though the something else may not be as effective. Often we see that in situations where a practice is changing, and I'll give a good example. And for many of you who work in labor and delivery, things may have changed again. But I was the labor coach for my niece when she had her baby. Her baby was born early, only 32 weeks, but she was almost 10 pounds because my niece is diabetic. So she had a very big baby very early. And she was having a very, very difficult labor, and she was young, right? She was very young. So she was having a difficult time. And the nurse was working with her around her contractions and pushing, and had corrected me when I had tried to count with her contractions. This is an old-fashioned way, the nurse told me, that we would actually help people to continue to push through that contraction by counting. So they could try to get them a good long push. And as this nurse had explained, they'd recently had an in-service where they were taught that it's better to let a woman just push as long as she can, as opposed to trying to force her to push for your count. Interesting. And I could recognize that, and that would make sense, and I would hope that the data would support that. But as my niece got into a little bit of distress, several biases come in here. A charge nurse came in to help out, very authoritative, and also regressed to that old practice, the known of counting the pushes and trying to force my niece to push for that count of 10. So the younger nurse, who was struggling a little bit with the fetal heart monitoring as well in her own way, saw that. She looked a little embarrassed because she had just sort of chastised me about not counting. She saw the senior nurse that, in a very authoritative way, revert back to what was known, the known, which is she's in distress, we need to get her to push, and we need to get her to push to a count of 10, versus what they had learned as a new practice that was more effective, which was the non-counting, to actually encourage her to push as long as she could, backed up by data. Isn't that fascinating? So we see many biases coming into that situation. So we tend to follow what we know, particularly in situations where it feels like there may be some pressure, we revert back to what is familiar to us as opposed to following the best path, which may be a little bit uncertain to us or new to us. And I'll give an example for myself, and Leslie laughs at me all the time, and it's a terrible example, and I recognize and I hold myself back. When I was a young nurse, so long ago, when patients had a low blood pressure, we would put them in a position called Trendelenburg. And Trendelenburg is where the head is down and the feet are up. And the theory at that point was that that would help with blood circulation to the core, to your brain, and to your core organs. And so that was effective when somebody was compromised, in a cardiac compromise due to hypotension. But ironically, this Trendelenburg position that had been used for many hundreds of years had no evidence to support it. And when they actually did look for that evidence, it wasn't there. So there was no difference in outcomes whether we put a patient in Trendelenburg position or we had that patient lying flat. We wouldn't have their head up, right? Because we do know you're trying to have the patient pump their blood against gravity, but putting a patient in Trendelenburg did not support that. So we know that, right? And we know that it's an established fact. And for me, I continue to struggle to this day when a patient is severely hypotensive and is compromised with wanting to put the head of that bed down. I can't, and you'll see many old nurses like me just desperately wanting to do that because in a situation where you're trying to do everything you can and you feel a little bit powerless because it was something unknown to us. It was familiar and we knew it. And now what we know is that it actually causes its own problems and may be detrimental to the patient's health, but still you are so drawn to do it. And so it's an interesting example of what we tend to go down the path that we know. So where does all this lead to us? I think it's just really important to recognize we always have to follow the data. That so many times during the course of a shift, we are thinking about a whole bunch of different facts, but also we're impacted by the situation, by the people around us, by our own past clinical history, and in a very good way. We say, where have I seen this before? But also the risk is in a negative way as well. So some of these subconscious thinking biases that can really impact patient health. Important that we follow our own intuition and our own hunches, and important that we ask ourselves, what's making me think this? So to step back, sometimes you just have to step back from the situation with a clear view, right? And think, okay, how did we find ourselves here? Like we're in this situation with this patient, what led to this and what thinking led to this? And you sometimes may uncover many biases and many assumptions that have not been explored. Always have a repertoire of questions that help you to get answers that are not predetermined. So you're not just asking the questions. Remember that example of that woman with a sore arm? You're not just saying, do you remember hurting yourself? You're asking questions that are broader. And these are good examples from my practice in the emergency department. Is there anything at all about you or your situation that would be helpful for me to know? Well, as it turns out, both of her brothers had MIs in their early 50s. Remarkable, but you have to ask the open question and not even just get to the cardiac, ask the open question. Or is there anything more you'd like to tell me? An excellent question with patients at the very beginning of the day. Is there anything more you'd like to tell me? Not just, are you having any pain? Did you sleep well? Let me take a look at how your incision is healing. Is there anything more you'd like to tell me? And what if that more is, yeah, you've been having some indigestion or something. We assume that we will get all of the information that we need through our assessments. We assume that we all have time to do a head to toe, and we are supposed to do a head to toe. But in that race, sometimes through all of our patient assignments to do a very thorough and pristine head to toe, it's also important that we stop and really leave that open-ended question on the table. Is there anything more that you would like to tell me? And if anything comes up, if you think of anything, just let me know. Important that we always ask questions. So we keep that spirit of inquiry with us at all times, that we make sure that we acknowledge our mistakes. I blew it. I got that one wrong. I see now how that groupthink led to a certain situation, that we need to recognize that we're all learners, right? And that we work out our thinking strategies. We work on them and we work them out. We try them, right? So we take them out for a real workout, and that strengthens them, right? And the same way that you work out your muscles, you're working out your thinking strategies. And I'm going to show you as a separate link, the story of a patient who really struggled. He really had catastrophic hospitalization that led to catastrophic outcomes, because some of these exact biases, right? Some of these exact biases are what impacted his care. So I'm going to ask you to watch that short YouTube video, and I'm going to ask you to really think, what biases do I see here? Do I see authority biases? Do I see ambiguity biases? Do I see groupthink happening? Right? So where does that take you? And you'll look at, as you look at that story, I think it'll really have an impact on you. I hope you enjoy thinking about your own thinking biases, and on we go with more discussion. So over to the next slide, and you'll see, or actually I'll post the link separately for you on the web. And as you watch that video, I really hope you have an opportunity to honor the very catastrophic loss of life that you're going to see in that, by saying, I'm not going to find myself there, or I'm going to do everything I can in a very honest way to try not to find myself there. Thank you so much, and I will keep talking. Enjoy this beautiful day.